I'm Dr. Rebecca Bowers, and in this video I will be discussing Chapman's reflex points. Chapman reflex points are believed to be a type of lymphatic reflex response caused by afferent sensory information coming from diseased organs or musculoskeletal structures stimulating reflex changes in the lymphatic system via the spinal cord and/or the autonomic nervous system. This nervous system-mediated alteration to lymph flow is associated with a Chapman point, which is often described as a gangliform contraction. They are within deep fascia, like an aponeurosis or the periosteum surrounding a bone, and feel like taut tissue, all contracted towards the center of the point in a plane parallel to the skin. At the center of the point may be a small, smooth, cyst-like structure whose firmness some liken to that of a tapioca pearl, like the ones in a boba drink. These central cyst-like structures occur more often for anterior Chapman points than posterior ones. They are sometimes grouped into patches or bands and are most often tender to palpation. In an optimal state of health, the patient would have no active Chapman's points. Chapman reflex points are paired anteriorly and posteriorly and consistently found in the same locations. Each pair is associated with pathology of a specific distant structure or structures, and there are charts for many of the known points. These two charts can be found in the Glossary of Osteopathic Terminology, which is found in the back of the Foundations of Osteopathic Medicine textbook. The anterior points are used for diagnosis more often than the posterior points, as they are easier to palpate than the posterior ones. Once you learn how Chapman's points feel, you may discover other ones. For example, I have found that there is another point anteriorly that has shown up in patients of mine who have had fallopian tube pathology. This other anterior point is found here. Like any other physical exam finding, they are useful when appreciated within the context of the individual's unique case. A clinician might palpate these points to help aid in making sense of a patient's other signs and symptoms, or they might notice one on exam and ask the patients more questions related to the structure that particular point is associated with. These reflex tissue texture changes are linked in the nervous system to their associated structures. Sensory information from the Chapman's point also feeds into the spinal cord and can affect the related parts too. That is why it is important to look at Chapman's points during recovery from a disease process, since they may be contributing to a pathologic reflex arc affecting autonomic tone to the diseased or formerly diseased structure. Untreated, they could interfere with the nervous system's response directing the health of the related structure. We diagnose using the anterior points, but both the anterior and posterior points should be treated until there is no longer a feel of fascia contracted towards the center of the point. When gentle rotary myofascial release is properly applied to the point, it usually takes no more than 20 seconds to treat. Treating these points is most helpful if their cause is being or has been adequately treated. Otherwise, these points will soon reactivate. Treat any other somatic dysfunction related to the patient's clinical case. As with any medical procedure, one must consider the known contraindications as well as the clinical scenario of their unique patient's case.
To treat a Chapman's point, we're going to use gentle rotary myofascial release. I just push in to feel and engage that contracted tissue, and I just do little circles. I might go one way and then the other. You might notice a preference that as you go in one direction clockwise or counterclockwise that things start to relax.
Dr. Owen, who worked with Dr. Chapman, who discovered these points, recommended treating the anterior point first, then the posterior point. I treat both the anterior and posterior points at the same time. This is helpful because it cuts down on the time needed to treat the points, and having one hand in contact with the anterior point while you are palpating for the posterior point helps you locate the posterior point. Because they are linked autonomic dysfunctions, and when you gently press the anterior point, you should be able to feel a brief palpable change at the posterior point if your other hand is on the correct spot. Or vice versa, if you push the posterior point, you'll feel a tissue texture change at the anterior point.
So let's say that you have a patient who you're suspecting disease involving the adrenals and you want to look for a Chapman point. Looking anteriorly first, So is it okay if I lift your shirt up to expose your belly? So anteriorly, you're going to look for those by finding the umbilicus. You're going to head out laterally 1 inch, whichever adrenal you suspect, or check them both. So if I'm looking on the left, I go 1 inch lateral for the umbilicus. If I go about 1 inch, obviously these are approximate, someone who's really tall versus really short, it's going to vary by a few millimeters or so. So 1 inch higher is going to be kidneys. So if I go another inch above that, it should be adrenals. Remembering what a Chapman point should feel like. Okay. And he actually does have a little bit of that contraction where everything fascia-wise goes kind of being pulled towards this little central point. As far as that little gangliform contraction in the center, he does have a little bit. Is it tender at all here? Yes. Okay. So I found it with my right hand because I'm right hand dominant, but I'm going to switch to my left because I like to find the corresponding Chapman dysfunction in the back. So that should be on the lamina of T11, T12 area. Now the thing is, if I'm not quite sure exactly, 11, 12 is reasonably easy as far as, where's that bottom rib? Oh, it should be 12. Heading into the T-spine, feeling where the laminas are. But it's a little bit more challenging when you're looking for something kind of in the mid-T-spine. Oh, am I on T8 or T9, etc. But just to make sure that I am on the corresponding point, when I encounter a neurologically linked spot, like right here, see which one is that, 12 or 11. His case, 11. When I push on that, what I feel is under my finger in the front, there's just this slight little, this. It's like the tissues just do a very hint of a contraction. And that should be with any kind of neurofascially linked dysfunction where the autonomic system is involved. There we go. So for me then, I just treat them both at the same time rather than treating one and then treating the other one.
When is a Chapman reflex point not a Chapman's reflex point? Never if you know what a Chapman's point feels like and can distinguish it from other dysfunctional points that might occur in similar locations. For more information on distinguishing between common dysfunctional points, watch my What's the Point video. For further reading, consider one or more of these texts. Please view Owen's text through a historical lens. While not as old as Hippocrates or Galen, there are things in it that may not have stood the test of time. Nonetheless, I found it to be a useful resource. I have made this video as a resource for other physicians and bodyworkers. Do not attempt to perform any manual techniques unless you are a physician or bodyworker or a student under proper supervision.